Hey guys, welcome back to the Foam Frat Podcast. Tyler and Sam. We're going to talk about external ventricular drains in this episode, and we're talking with Alaina Martini. She is a flight nurse. She was a neuro ICU nurse. Sounds like she still works some flight appreciation shifts, she calls them, in the neuro ICU. And we go over the logistics of the EVD. And so I'll get in the actual episode. You'll hear how I came to the idea of reaching out to her, what sparked me to reach out to her to talk about this specific topic. But Sam, as you were going through this episode, what were some of your thoughts?
I was thinking that you've transported EVDs 2 more times than I have. I've never done one of these transports before. But if I was going to do one, I would certainly want to listen to this first. It was really well done. I was thinking what I would do is prime the audience's brain a little bit to think about holes being drilled through the skull really quick. Something that I was thinking of, what allows me to like follow this conversation, because before I started listening to it, I was like going through the anatomy in my head, and this is the way
no pun intended.
Yeah. So this is the way that I was picturing this, or this is what I think would help prime people to listen to this episode, is that when you think about this whole like loop, right? So on one side you have your aorta, and then you're going to have eventually a carotid artery coming up off of that, right? And so I think about the driving pressure that's coming up through there, which is your mean arterial pressure, right? So it's like, okay, MAP is coming up through the carotid artery. And then I think about it like 3 points of resistance. And the first one is going to be obviously the intracranial pressure, and the difference between that MAP and the ICP is your cerebral perfusion pressure, which is like the big thing that you're concerned about, right? So think about, okay, pressure comes up, meets this first point of resistance. You guys went into a little bit of like the Monroe-Kelly doctrine. There's only so much room in like a fixed cranial compartment, right? So you got like the brain itself, you have the ventricles, which contain the cerebrospinal fluid, which this external ventricular drain is going into and helping drain. So it's like one thing in there that's helping to relieve that pressure or resistance. And then the arterial and then the venous blood. So it's like the first point of resistance, and then you come down a little bit, and then you think about like, okay, that pressure has to drain now. So I have my jugular veins, and then I also have my thoracic compartment. And that's like another, when I learned this, I was like, oh man, that makes a lot of sense with, the brain draining down, is that there's another formula that you can use for that cerebral perfusion pressure, which is MAP minus jugular venous pressure. Because if you can't drain it, that pressure is going to build up kind of like, back in the stream, back to the head. And so that's 1 point of resistance. And then the other point of resistance is the thorax, which is, you guys go into a little bit like ventilator dysynchrony is really bad. So that's what helped me kind of like prep my brain for this. No pun intended, but like, yeah, pressure coming up. The difference between those two is your cerebral perfusion pressure, and then 1 point of resistance, head, 2, jugular veins, 3, chest. And this EVD thing, when I think about it, I'm like, okay, that's like one of those points of resistance that you're trying to relieve the pressure on that a little bit, while keeping in mind what you guys talk about with head and neck position and the head of the bed, because gravity is working on all of this, and then the thoracic compartment as well. So that's what helped me a little bit.
Yeah, no, absolutely. Well, awesome. Let's roll the episode.
Let's do it.
All right. So, Alaina, tell us just a little bit about yourself and your background before we get into the conversation.
Absolutely. First of all, thanks for having me, Tyler.
Yeah, absolutely.
My name's Alaina Martini. I am a flight nurse at Allegheny Life Flight. It's in Pittsburgh, PA. Been flying with Life Flight for about 3 years. But prior to Life Flight, I got my experience as a neurosurgical ICU nurse, as well as an ER nurse. So I still pick up in the ICU. As I was saying earlier, it's my flight appreciation shifts, if you will.
Yeah. No, that's awesome. And you were in one of the live classes that we were teaching with Foam Frat, or I was teaching. And I do this class called External Ventricular Drain Transport Logistics, or transporting the EVD. And Alaina was just like firing off all these answers. And then somebody asked a question and I was like, I don't know. And then she came through and I'm like, all right, who is this Martini person? Let me look this up. And so I reached out and asked if you would want to come on the podcast, because to be honest with you, I've transported 2 of these things. Those transports were probably 35, 40 minutes. Yeah. In your background, having sit in a neuro ICU and watch these and see people go to CT and then come back from CT, I had so many questions regarding like the transport logistics. So what I thought we could do, and actually after that class, I had several people email me and they were like, hey, get Alaina on the podcast. We want to hear more about this, because it's not something you're doing all the time, right? You don't normally transport somebody with an EVD in, because typically the places that are putting these in are the places where they're probably going to stay. Exactly. However, it does come up, and like I said, I've done 2 in, my time flying. And so it is one of those things that I'm like, all right, what are the things you got to remember? So what I wanted to pretend is, you fly, pretend that you have one of your colleagues text you and they go, Alaina, I'm going on an EVD transport right now. What are the things I need to know? And you got to like summarize years in the neuro ICU into a few text messages. What would that look like? And then we can dive in deeper into the other stuff.
Yeah, absolutely. That's actually funny that you frame it like that, because I did get a text like that about 3 months ago. Like, hey, we're going to get an EVD, what do I need to know, kind of quick and dirty. And so yeah, that's a really good way to frame it. I would say quick and dirty, what you need to know, why did they put the EVD in? Because that's going to kind of help you know what to assess for if you're looking for changes in clinical condition. So absolutely, that would be the first question that I'd want to know. And then the next things I'd want to know are more logistical sort of things. So at the bedside, asking like, when was this placed? What is it ordered to be level and open at? Or is it even ordered to be open and draining? Maybe it's ordered to be closed and monitoring ICP. So I would want to know both of those things. I also want to know, how much CSF are they draining per hour? What's their average ICP? Anything that could kind of help you establish a baseline, obviously, is going to help you note deviations from that baseline much quicker. And then the last thing I probably would want to know is just the color and texture of that CSF, because that will also help you detect changes a little bit more quickly. As far as, leveling, zeroing, that kind of stuff, it's very similar to an art line. Everybody gets really, really worked up about like, I don't remember how to level it. I don't remember how to zero it. I'm always like, guys, arterial line, we do this all the time. Same thing, just a different looking kind of system. So that's, if someone asks me how to level and zero, that's typically how I would walk them through it.
And make sure you clamp it before you move them, right?
Yeah, always clamp. When in doubt, just clamp it.
Just clamp it, yeah. So the 2 that I've transported have been subarachnoid hemorrhages with obstructive hydrocephalus. And so from what I understand, you don't see these put in for, epidural or subdural bleeds, because the whole purpose of the EVD is to drain the CSF, right? And to free that CSF up if it's obstructed. Because, from my understanding, and correct me if I'm wrong, but you get this bleeding that occurs typically within like one of the vessels of the circle of Willis, and it can actually obstruct the ventricular foramen where the the lateral ventricle, where the actual CSF is produced. You can obstruct the part where it goes down into like the third ventricle. And so then you're just creating in that lateral ventricle, you're creating the CSF, and it's getting bigger and bigger. So not only are you bleeding into that space, but now you have an obstructive hydrocephalus that's occurring because of the CSF. So if you had something like a let's just say an epidural bleed at that point, draining CSF off doesn't make a ton of sense to me. But in your, experience, what have you seen?
The most common reason or indication for an EVD that I've seen is absolutely that aneurysmal subarachnoid hemorrhage. Generally, it's like a ruptured aneurysm, like you were saying, the vessel in any of the vessels in the circle of Willis. You'll also see EVD insertion sometimes with just regular intracranial hemorrhage. However, it has to have that extension either into one of the lateral ventricles or into the subarachnoid space. Usually you'll just see it like an ICH with ventricular extension. A little bit less common, but it does occur. And you'll also see sometimes an EVD insertion for a meningitis or maybe just some really funky kind of bacterial infection. And it follows the same principle like you were saying. So obstructive hydrocephalus, that bleeding can kind of obstruct that foramen of Monroe, or the bleeding can also, or the bleeding and or blood products, inflammatory products, etc., can also obstruct the arachnoid villi, and that's where the CSF is actually reabsorbed. So that can also be a cause of hydrocephalus. So you don't necessarily have to have like that clot that's blocking the lateral ventricles from connecting to the third ventricle, fourth ventricle, etc. You can also just have issues in those arachnoid villi, and they are just kind of scattered throughout the subarachnoid space as a whole. And that's where the CSF is actually reabsorbed. It's like a one-way flow through there. So the blood products, inflammatory products, cytokines, whatever it may be, can obstruct those villi, and then you can't reabsorb the CSF. So it causes the same problem, increased ICP. But you'll see that sometimes with the subarachnoid hemorrhage, but you can also see that with like meningitis or just any number of really strange bacterial infections that can occur in the brain. But most often you're going to see it with aneurysmal subarachnoid hemorrhage.
That's really interesting. Yeah, and that totally makes sense. Maybe you have some blood that makes it through that little spot between the lateral and the third ventricle, but then you could have your clot build up somewhere else, or like you said, in the villi, which kind of surround the entire thing, and then you back up the entire system. You mentioned that you would ask, what color is the CSF? What is your assessment like? What are you thinking? What's your model like that you're going through when you ask that?
Yeah, so the reason why I want to know that is, so CSF typically should be like a very pale yellow color, almost like a sanguinous. It almost never is after EVD insertion, because generally we're inserting it because of some type of a bleed pathophysiology. So you'll usually see like a serosanguinous and even almost like a sort of cherry red color. All of those are on the range of normal, if you will. But I always want to know what it has been generally looking like for the bedside RN, because one of the bigger and more life-threatening acute complications with, EVD insertion is rebleeding. And so I want to know what my baseline is, because I want to be able to detect that rebleeding really, really quickly. Only seen probably 2 people rebleed. So their aneurysm maybe re-ruptures, or they have a secondary aneurysm, or maybe an arterial venous malformation that like they're so sick, we just haven't had time to secure all of those things. So I've seen them rebleed that way, and you're not going to miss it. It's the color and the texture changes, like that kind of cherry red color I was talking about is normal. Oh, yeah. It's more like that frank, bright red blood, and it's thicker because it is literally blood. And so I always want to know kind of the baseline of the color, because I want to be able to pick up on that rebleeding, because honestly, that's probably the quickest life-threatening and most catastrophic complication that you're going to see. And in the transport realm, we don't have access to an OR, right? So if I see that in flight, I mean, it's an immediate command call, obviously. I'm going to expect some osmotic diuretic just in hopes to try and normalize some semblance of like that blood-brain barrier, or blood-brain CSF, Monroe-Kelly doctrine sort of thing. And then, hope we're close to our receiving hospital.
Hope you're on short final. So have you've seen, I'm sure, one of these actually put in, right? Like the procedure when they're doing it?
Lots of times. Mm-hmm.
So it blows my mind. Here, let me grab my little skull here. Hold on a second.
Okay.
All right. So I don't know if you can see that. So I have this little hole. Yeah. Mm-hmm. So I've measured up like where they typically put this in. Mm-hmm. But what's interesting is when you take the top of this guy's head off real quick. Mm-hmm. When you look at it, that's just like brain tissue that it's going into. So what I'm trying to figure out is, when you're putting this catheter in, is that causing any damage to the actual brain tissue? Like, how does it get, because you look at where the lateral ventricle is, and it's like, here in this little middle part, or right up in here. So like, how does it get down there? Is it just car ramrodding it through the brain to get through there? Or have you ever asked that, or they've explained that?
Yeah, I think I could generally explain that, because I wanted to know the same thing. I'm like, how do you know when you're putting that in that you're not putting that through something really important?
You're erasing somebody's childhood.
Yeah, exactly. Like, they didn't sign up for this. So what they'll do, and they use CT generally to kind of guide and give them their landmarks, if you will, but they want to use that frontoparietal part, and they're going to aim it more towards the midbrain, because obviously that's where the lateral ventricles are. But they use that trajectory also because the primary like motor and like sensory motor cortices are like more towards the frontal part. So their theory is if they're aiming back towards the midbrain, they're going to miss all that important part of the brain, if you will. So that's how they know that they're not going to, like you said, accidentally erase somebody's memory or cause more damage than needed by putting it in. And generally what you'll see when they put it in, and I'll say only, I mean, it is pretty deep, but the maximum depth you'll see them usually put that catheter in is about 7 centimeters, because if they really go any further than that, they've missed a lateral ventricle in most. So it just keeps going. Yeah, I ran out of catheter. How did this happen? No. So you'll see them as they get, closer-ish. What they'll do, they have it's essentially like a guide wire that they have in that rubber catheter. They'll pull the guide wire out and they'll hold the end of the catheter up and just wait to see if they see CSF dripping. And then when they do, then they know they're in, and that's it. They're done. They'll put a cap on the end of that catheter when they know that they're in, tunnel it back through the skin, and then suture it to the head.
And you mentioned in the class that some of these are under a lot of pressure, like they can shoot across the room, right?
Mm-hmm. Yeah, the highest I believe I've seen was 83, which is, I know people that have seen higher pressures, but the highest I've ever seen was 83. And that's actually something else that I like to ask. I kind of have a little checklist for myself. Like if I go to the bedside, this is what I want to know from the referring facility nurse or whoever's taking care of the patient. And that's one of the things that I like to ask, like, hey, what was their opening pressure? One, because when you get to the receiving facility, the first thing the neurosurgery resident's going to ask you is like, hey, do you know what the opening pressure was? And really that's just a predictor of clinical outcomes, essentially. It doesn't tell you a whole lot more than that. Mm-hmm. And to put it simply, generally, the higher the ICP, they're more likely to do poor, or with their more normal ICP. So that opening pressure is measured like as soon as they connect the catheter to the actual drainage system, and you'll get that opening pressure right away, because we generally will have it like leveled. So all we'll have to do is zero it, and we'll get a pressure before we let anything drain out.
Yeah, it was interesting in the class. Like I was thinking the first thing you'd want to do is drain that pressure, right? So like you have that little stopcock. You can either go towards the pressure transducer or towards the drain. And I was like, which one would you guys turn it to first? And you were like pressure first, and I was like, oh yeah, that's what I meant, pressure first. But because that's an important indicator. But my brain is like, obviously, I've never seen one of these put in. I've only transported them. Yeah. But I'm like, oh yeah, let's get that all out. It's like I'm doing a needle decompression and being like, before the air can come out, I want to see what the pressure is inside the chest. So for me, I was like, I didn't understand that, but it totally makes sense. And it's what, a second that you get what the pressure is, and then you open it up.
It's generally, they say about 30 seconds to get it to stabilize till you're going to get an accurate reading. For that first opening pressure, I'd say it's like, we'll do about 30 seconds max, just till our reading levels out and our waveform looks appropriate, and then we'll open it up and let it drain. But you're right, it is counterintuitive because you're placing that EVD because you have increased intracranial pressure. So of course the first thing you would want to do is alleviate that increased intracranial pressure. But yeah, we get the opening pressure first, and then we'll just leave it open to drain. Depending on, the level of the drain that's ordered by the physician. Mm-hmm. I think you had mentioned.
Oh, I'm sorry. Go ahead.
Sorry. I think you had mentioned millimeters of mercury. We actually typically, so on an EVD setup, and it's different depending on where you work or who you buy them from, I'm sure. But you'll see there will be two sides. One side will be numbers in millimeters of mercury, and the other side will be numbers in centimeters of water. And the neurosurgery resident, physician, whoever, will order that EVD to be open at a certain setting. And we actually use the centimeters of water for that rather than the millimeters of mercury. So they'll say, open it at 0, open it at 5. It goes from -5 generally up to about 25 centimeters of water. So once they put the EVD in, they'll take a look at the opening pressure, also look at their CT scans, because they want to see like how big the bleed is, so, that can kind of help them predict where they should open it at. But one thing also that I wanted to say that's on my checklist of things like that I absolutely need to know is, so they're placing this for an aneurysmal subarachnoid hemorrhage. Generally, that's what we're going to see. Is the aneurysm secure? That's something that I ask every bedside anybody, because you need to know that, because that really should greatly affect the level that the drain should be ordered to be open. So if you get there and they place the aneurysm or place the EVD, aneurysm's not secure yet, which I think would probably be the majority of the transports, right? Because I would think like you're taking them to somewhere that they can operate, or take them to IR and secure that aneurysm. But, maybe you do run into a situation in which they've already secured the aneurysm and something else is going on and now you're transporting them. But back to my initial point, I would generally expect that the aneurysm is not yet secure. And in that case, be very careful if they tell you to open the EVD up anywhere less than 10. So if they say, oh, go ahead, open it up at 0 to drain, go ahead, open it up at 5 to drain. The aneurysm is not secure, so essentially that ICP is kind of acting a little bit like a clot, if you will, like a scab. You're putting pressure on that bleeding area with the increased ICP. And if I'll open it up at a lower gradient, so 0 or 5, it's going to allow more CSF to drain off. But then you're going to lose that CSF, and all of a sudden now you don't have any pressure on that aneurysm, and you're at a much higher risk for rebleeding.
Oh, that's really interesting.
Yeah,
so when you say secure, you mean that they've actually gone in and stopped the bleeding?
So if the aneurysm's secured, they've gone in and they've clipped it, or they've gone in and they've put coils in so that pocket can't fill with blood anymore, and then you're not at risk of re-rupturing at all. But until then, you definitely don't, I would never open that EVD less than 10. You'll generally see them about 10, 15, sometimes maybe even 20. Again, seems sort of counterintuitive because it's higher up on the transducer, so it does require a higher ICP to be able to kind of overcome that gravity and drain. But you don't want to drain too much, because then you're in a much bigger issue if that aneurysm re-ruptures.
Yeah, and just if you're listening to this in your car and you're like, I'm trying to visualize what this is, we'll put some pictures and stuff in the show notes. And then also, Alaina, you keep mentioning this like mental checklist. You think you could turn that into like a physical checklist that I could throw in the
absolutely
the podcast notes?
Yeah.
Just what does Alaina think when she goes in? WWAD. What would Alaina do?
That's a little scary. Yeah.
When I did mine, the referring said, I asked, do you want us to, have you guys considered hypertonic, 3% mannitol or whatever? And he was like, absolutely not. He's like, don't give any hypertonic or you could kill this patient. And I'm like, God, I'm glad I asked, because typically you think of a bleed, you're trying to make more space, the Monroe-Kelly doctrine, like you said. And, the more I dug into it, when you think of like a trauma bleed, or like an epidural or subdural, you think of like cerebral swelling, like the hypertonic is really more so for like the cerebral edema that you get. And then you look at the EVD more so for the actual CSF. However, when we got to the receiving facility, the first thing they did was hang hypertonic saline. And because the ICP kept going up, and they were like, no, that's not going to kill them. So I was like, what is the what's the consensus on this? Do you ever see patients, and this was a subarachnoid with obstructive hydrocephalus, do you see them, if it starts to get really bad and they can't control that ICP, going on some sort of osmotic therapy?
Oh, absolutely. If it's an acute increase in ICP and, maybe we're thinking we need a surgical intervention because they need to do a hemicranie, take the bone flap off, they will 100% get a bolus of 3% or, mannitol, osmotrol, depending on the facility, what they prefer to use. But most of our aneurysmal subarachnoid hemorrhages would generally be on a 3% drip, like a continuous drip. So we would titrate it anywhere between like 30 cc's an hour and 60 cc's an hour. It's generally the upper limit. And it would be titrated based upon serum sodium values. So you draw serum sodium level every 8 hours. And then depending on what your level came back at, we would titrate the 3% either up or down. They like to keep them a little bit like hypernatremic, but really no greater than 155. So it's nothing like insane, crazy, not like a 160, 170, but just a little bit on the higher end of normal.
And definitely not lower.
Correct. Definitely not lower. They will usually, like, if you have someone like 135 sodium, like they're probably going to get a little bit of a bolus to keep that sodium up, like 140, 145 ish. So we'll do it concurrently. It definitely will not kill them. And they'll be on the 3% to a couple days generally, just depending on how their ICPs are and also the size of the bleed. Your larger bleeds, they're going to be on 3% for longer than,
and they're
just
giving that for cerebral edema to pull fluid off?
Mm-hmm. Pull
Because you can't really pull CSF off, can you? I mean, or not pull it off, but can you water it, not water it down, but you know what I mean? Like pull the water constituents out of it?
No,
I don't. Mostly just the edema?
And that's a good question. I don't think so, just because the blood-brain barrier is such a powerful thing. And that CSF is, you secrete about like 20 cc's an hour, regardless, at least 20 cc's an hour. So I would be surprised if the 3% could work like as quickly as you're like making it. It's pulling, products out of your CSF. But it's generally just for the cerebral edema and the mass effects that you're going to get with a large bleed, regardless of if you have an EVD in or not. Because they're kind of controlling two separate parts of the bleed, right? So the CSF's a little bit more for like edema, the blood sort of part of the Monroe-Kelly doctrine, whereas the EVD is for the CSF. But we will typically have people on 3% just for a couple days. I can't think of an instance in which you would kill somebody if you gave them 3%.
I think he was being a little hyperbolic, or maybe he just had a bad experience once. But I was just like, oh my God, whenever somebody says they could kill someone, you're like, right. Wow, I'm glad
you pay attention.
I'm glad I looked that up. All right, so he was full of crap with that, so that's good to know. The other thing I wanted to talk about was the clamping idea. So whenever I do that class, there's some places that are like, our guidelines are to clamp for the entire transfer. And some people are like, no, it's put in acutely. It's there to drain. So we're going to clamp it when we move them from A to B, just because of the leveling, right? So you're not draining and then putting it all back in. But then when you get to like a spot where you have it leveled and set up, opening it up to drain. What would you recommend?
I would say, depending on flight length, I guess I should preface this. So if you're doing a short hop, like a 12-minute sort of flight, they could likely tolerate the clamping for that entire time. But I would say if you're in the aircraft, you're good to go, you're flying, I would level it, zero it, open it up. Because that is, like you said, that is what they put it in for. I feel like people think like, oh, if we clamp that EVD, we got to hurry up and unclamp it because our ICPs are going to go through the roof. Could definitely happen in some patients. Some patients acutely don't tolerate clamping like at all. But most patients can tolerate 15, 20, 30 minutes because in the hospital, if we're taking them down for a CT, which is all the time, or an MRI, in transport, we clamp them. So as soon as we kind of take it off our transducer, like it's clamped and we just lay it on their chest and stays clamped through CT or even through an MRI. And then once we get back up to the bedside, we put it back on the transducer level 0, open it. Most patients can tolerate that. That's one of the other things on my little checklist, like, hey, have you guys tried a clamp trial? Or, the last time you took them down to CT, when you came back, how is their ICP sort of thing? Because some patients truly can't tolerate the clamping, but most people can. That being said, I think most people's flights are a little bit longer than, the 10-minute sort of like lift and land kind of thing. If that was the case, I would absolutely zero it, open it, because that's what it is there for.
Could you, when you guys are taking them to CT, are you still measuring the ICP even though it's not draining? No.
So we'll take the actual drainage part off the transducer. So we really don't even have anything to measure it against. There's some EVDs that it's all one big plastic piece. So the drainage chamber and the transducer are together, and it's just like a big kind of bulkier sort of piece. But even if you take the transducer with you, you don't really have anywhere to put it where you could level it with the tragus or like the foramen of Monroe. So if you could hook it up to your monitor and measure an ICP, but what you're going to get is generally not going to be accurate, because if you drop it, if it's below the level of the ear, you're going to get generally false high ICP. And if you have it, too high above the tragus, you're going to get a false low ICP. So we usually don't measure. What we will do is keep an eye on their neurological status, obviously, but the first clinical indicator of an increasing ICP is going to be your level of consciousness change, always, 100% of the time. It's a little subtle. Sometimes, people think like, oh, it's the blown pupil, but like if you've gotten to the blown pupil or, the Cushing's triad, you've probably missed the level of consciousness change. So while we have them clamped, we're obviously keeping an eye on their baseline level of consciousness.
Are most of them intubated or no?
It depends. I'd say maybe 60%.
60%, yeah.
Upwards of 60, but I'd say about 60%. So it's a little bit more difficult when they're intubated, but when they're not.
Sam, my buddy Sam, Sam.
Sam
Bone Frat. Yeah, he was visiting, I believe, a friend of his wife who had been in an accident, and they were in the ICU. They had one put in, and he was saying it was like crazy when they became desynchronous with the ventilator, how the ICP, you would just see it like coming over into the drain, or if they turn their neck just a little bit, you'd see the ICP jump up, and you actually have like real live footage of it when it's open to the drain of the things that spike the ICP. And ventilator dysynchrony, the position of the head, just turning the head just a little bit and reducing that venous drainage. He was like, it was crazy to see that and watch that. I'm sure you have the same experience with watching these people in the neuro ICU. You probably have a different appreciation for the things that we do in transport, because that says keep their head elevated at 30 degrees, or it says to keep their head in a neutral position, or to make sure that they're not desynchronous with the vent. Do you have any tips or tricks with that, or anything that you've witnessed or experienced when it comes to the things in transport that we do that increase ICP?
Yeah, that was on my logistics notes here. To just kind of mention exactly what you just said. You have to keep that head midline, and in transport that might mean just more sedation. Honestly, we used to in the unit, like we'd use towels or something too to kind of just help stabilize it. I heard talk of someone somewhere trying to use a C-collar. Please don't do that, because
oh yeah, who would ask that? That was not going to be my next question at all.
Yeah. No. Because why are you keeping a midline? Like you said, you want to promote that venous return, and so the C-collar is not going to help there. And then also keeping that head of stretcher, if you can, 30 degrees, because again, promotes venous return, but it also we'll use gravity to kind of divert that CSF down into the spinal system and away from the cerebral port, so that'll also help lower your
that's interesting.
ICP. And which is impossible in flight or transport. Try to decrease stimulation as best you can. We can't do any of that. So again, I would probably, especially if they're intubated, just give them a little extra sedation if their pressure can tolerate it, because any change in their environment like that is generally going to cause an ICP. Also, like you said, vent dysynchrony, minimizing suctioning, endotracheal suctioning or oral suctioning, because both of those things will generally cause a transient increase in ICP. The transient increase, it's okay in you and I, because all the rest of our system is normal, but it is definitely detrimental to those patients that are like acutely ill with the subarachnoid hemorrhage. So those are the bigger things. And like some of that we can control, but the environmental stuff, just do your best. Sometimes we would put like a towel or something over the patient's eyes if we're taking them into the hallway, sort of thing. Does it help? Maybe. Does it make me feel better? Yes.
Absolutely. Yeah. When I worked ground, like I was like, maybe we should buy some headphones for people. and like just some like earmuffs, like almost like you would take to like a gun range, you know? And what's funny is in flight, we do that automatically to everyone, right? Do you guys do the same thing? I'm guessing you have like patient headphones that you put on, and you can bring them on comm and take them off if you need to. But on ground, it wasn't even a thing, right? You were just like, oh, that ambulance isn't that loud, but it is. I mean, it's a bread truck back there, especially if you're going lights and sirens, you know, or whatever. So something else to consider if you are a ground critical care provider, you know, get some Viper sunglasses and some, or what are they, Pit Vipers, and some headphones. But we had a little kit that we actually put together because we're like, hey, you know what? We noticed we don't need as much sedation if we do these things. They seem more comfortable. And that makes sense. I mean, there's some studies in the ICU too with the beeps and alarms and noises and how those patients, when they are in a sedated state, you know, how that can aid and enhance even delirium for those cases. So something to consider. Well, we talked about kind of the physiology of what's happened, or I should say the pathology of what's happening, some stuff with hypertonic, the logistics of the transport. What airframe do you guys fly?
We have EC 145s and EC 135s.
Any tips and tricks for where to hang this thing in the helicopter?
Yes. So
you have a cot actually, right? You have an actual cot that you lived in. So
that was
is that where you put it?
Yeah. So in transport, i.e. like from the bedside to the aircraft, I would say keep it clamped. Don't try to open it. You don't know. You're going to hit a bump. The doorway is this big. Like, don't hang anything off of the side, like EVD-wise especially. So I would say just clamp it, kind of secure it to their chest. That's generally what we do in the hospital when we're going from point A to point B. Once they're loaded and, you know, everything, you're good to go kind of in that sense. I would say we have an IV pole on the back of our stretcher. I don't know if you guys have that or if that's, you know, common.
We don't, no. So we have like a sled that we load in.
Oh, like on the side. Okay.
Yeah. So we don't have an IV pole on that. But keep going. Yeah.
Well, you're good. So you know, when someone texts me and said, hey, we're going for an EVD, like, where do we put this thing? I was like, oh, just pull the IV pole up. You can put the transducer right on the IV pole, because that's really what we do in the hospital. It's on an IV pole, just, you know, on wheels. So secure it to the IV pole. You can level it with the tragus, zero it, get it ready, open it up. If you don't have an IV pole or really anything you could secure the transducer to, what we used to do in the hospital, if they really couldn't tolerate being clamped at all when they're going to and from CT, we would just level the drain itself, like with the tragus, secure it there, tape, whatever you need to do, and open it up. That's a really good question, because another point too, you know, you don't want to necessarily like hang it from something, because
where it's swinging back and forth.
Yeah, that, and is it secure? Like, you know, everything needs to be secured. Maybe you have a hard landing. You don't really want that thing being a projectile in the aircraft. So
right, yeah.
I hadn't actually thought about that. Because we're you know, we have the IV pole, so that's what we do. But I hadn't thought, if, you know, you're with a service that doesn't have something like that, you know, what would be the best way to...
Yeah, we've gotten creative with using like some of the, just like the hooks and stuff that we have, and then securing it with like tape, because obviously you don't want it just swinging and hanging, right? No. But if you need to have it up, you know, you can get creative with whether you're using the back of this, you know, seat and taping it. The main thing is, like you said, that it's secured. So if something happens, you know, patient aside, this thing, like you said, doesn't become like a projectile at that point. And then we end up needing an EVD for our bleed, our head bleed. Awesome. Well, Alaina, this has been super helpful. Any of the notes that you took, like, for this as you were like prepping for it? Even though I know you know all this stuff off the top of your head, but I would love to have some of that stuff that we could put in the show notes, because people need a place they can go when they get the call goes off, the radio goes off, and you have a patient with an EVD in. You know, we've all had that moment like, crap, what are the things I need to remember about this? And the Impella, you know, these special equipments and stuff like that. So that would be super helpful. Anything else that we should talk about before we end this?
Trying to think. Just maybe a little bit of troubleshooting, because I think that might be the most common sort of issue that you run into mid-transport. The biggest thing that you'll probably see is like an obstruction or some kind of occlusion in that actual drainage tubing. So how you would pick up on that one, your ICP waveform should have three peaks, if you will, and they all should be descending. It's going to be pulsatile. It's going to correlate with your art line. It's going to correlate with your heart rate. So if you have that really nice, 3-peaked waveform, and then all of a sudden it's pretty dampened, it's a little flat, it's like with anything, work your way from the patient back to your drainage system. So you'll see maybe there's, maybe your tubing is kinked. Maybe there's a blood clot in the drainage tubing, or maybe there's a bone fragment or tissue or, something like that.
Right.
Acutely, if you can keep an eye on their mental status and their ICP, do you
Is
have
that
to
your
necessarily?
Cat coming in?
Yeah, there's a cat.
I thought I heard him open the door before the podcast. She's like, I have 2 cats. One of them knows how to open the door. So if they come in.
Yeah, this is the one that knows how to open the
Yep. Is that
He knows how to open the door, so.
What's his name?
George.
George. That is an
He's
amazing
invited
name
himself
for a cat.
in.
I was trying to remember what the waveforms are called for the ICP. So I was like trying to secretly like Google it over here, because I remember it was all one letter, right? And I think it's P. Is it like P1, P2, P3? Am I looking at the right thing?
Yes, I was going to say that's what we refer to them as, P1, 2, and 3. And there's a whole patho, your P2 is now higher than your P1, and that indicates this. I don't know any of that off the top of my head. Generally, I'm looking for 3 and, at a descending slope, and then I know we're good. But if you have maybe a longer flight and you find, okay, now I'm not getting an ICP reading, my waveform looks terrible, I'm not draining, maybe you do need to do something about it. Flushing the EVD, definitely I would not do without getting the blessing from command, whoever. However, there's 2 ports at the EVD, right? Or there's 1 port, the proximal port right by the patient's head, and then there's the port down at the drainage system by the transducer. If your obstruction is in the portion closer to the drainage transducer, it's so much easier, because all you got to do is just turn that stop clock to the patient, so you're not going to instill anything extra there. You could just flush it out towards your EVD.
You're just turning it off to the patient,
yeah.
Disconnecting it, flushing it, and then putting it back on?
We don't disconnect the system. The system stays closed. So generally what we would do is just turn the stop clock off to the patient and then flush
I see what you're saying.
distal, into the drainage tubing. Complication in flight, though, because we usually will only use sterile water to flush the EVD. They won't usually use normal saline. You can, but there's research that says the saline, it can irritate the brain tissue, and obviously you don't want that if you have an acute issue. But I would say sometimes, honestly, you can see the obstruction in the drainage tubing, and if you're even able to kind of push on it, if it's distal, obviously if it's towards the patient, it's something totally different. So I think you can kind of sometimes you can loosen it up and it'll just go into the drainage container. But I think that's the most common complication, if you will, in transport.
Is the obstruction mostly, is it blood, or does the CSF, can that actually get hard?
It's usually either blood, or sometimes brain tissue will come out through the EVD, or bone fragments. When they drill that burr hole, they'll try to do a really good job of fishing all the bone fragments out before they put anything in, but sometimes they don't get them all out.
That's a good point. I didn't even think about that, especially in a new one that's just put in. You can still have some of those bone fragments in there.
Yeah, so sometimes you'll see that. And another thing, in flight, are you going to be able to take care of it? Potentially, if it's a distal obstruction, but that's just another thing you would want to pass along. Sometimes they'll replace the whole drainage system. If it's a chronic issue, they'll just get rid of the tubing altogether and throw up a whole nother setup, and then a lot of times that takes care of it. But
that's interesting, because when you pick up the patient, you're trying to figure out how much was draining, right? So that way you know how much to expect. And then if you don't see that, then that would really make you think that there's something wrong, or if you see a dampened waveform, right?
That both of those things, the drainage isn't what you expect, dampened waveform, or if you can assess your patient's, mental status level of consciousness, and then they're, they were drowsy, but now they're borderline obtunded, maybe that's one of the things you should check first.
Awesome. Well, Alaina, I can't thank you enough for coming on. This was amazing. We'll put out a blog with this and with this episode, and we'll have you back on to talk about some more neuro stuff.
Awesome. Thank you. This was really good. I always say I'm still a neuro nerd at heart, so
we need more of those. Everybody's into airway and stuff. We need some more like kidney and brain people on FoamFrad to help us have a new appreciation for that stuff. So I look forward to seeing like your checklist and stuff. Thanks.
Absolutely. Thank you.
All right. Nice.